Good morning, everybody. Dr. Alex Vasquez here, and today's Sunday morning, February 14th, and I am just now finishing my second cup of coffee. And we are going to review right now, virtually and practically, this article recently published in JAMA Network Open. So I'm going to point out a lot of big and small details as I go through this. And really the reason I'm doing this isn't to spend a lot of time necessarily on this article, but rather to use this article as kind of a conversation piece. And this article is a really good conversation piece. This article tells you a lot. It tells you a lot about the American Medical Association. It tells you a lot about this particular journal. It tells you a lot about the people who participated in this study as investigators. It tells you a lot about the level of knowledge of nutrition in the medical profession. This article also tells you a lot about the level of knowledge of research design within the medical profession. And this article also tells you a lot about how the media functions. So, you know, I could critique this article, and I will in just a moment. I'll critique this article kind of based on the details, of course. But you know, from a conceptual standpoint, I think this article really provides a lot of insight. And, you know, I'll offer it to you as the reader or the person watching this video. What you could do, or perhaps what you should do, if you want to kind of fully engage in this exercise, is to read the article yourself, or at least read the abstract. But ideally, read the article yourself, see what your opinion of it is, and then listen to my review. So that would mean pausing the video right now. Listen to my review and see what my critique is. Now, I haven't spent a lot of time developing this critique. I've barely even finished reading the article. I started reading it on the couch, and that's why you'll see my notations, and they're kind of sloppy. But this isn't some huge formal critique and review. This is just casual. So here's how I'll describe this review: casual, somewhat disinterested. I would actually rather be doing something else right now other than doing this review, exercise or being outside or working on a different project. So I'm going to do this anyway because I think this is a really good learning piece. If I could be anything in the world, I would be a teacher in a good college or a good university. And if I were a teacher in a good university, we would use this article as a discussion piece among what I would hope are my graduate or doctorate level students. So for, you know, at the graduate level, let's see, I've taught undergraduate courses as well, undergraduate nutrition, for example. At the undergraduate level, well, I don't know if we can really get into that level of detail in an undergraduate course, but we probably could. But certainly at the graduate and doctorate level and postgraduate level, I mean, this article is ripe. This is a fertile garden of nuance and stupidity, if I must say so. So let's get into it. You'll see some of my markings on the video, and that was kind of to cue me into areas where I need to maybe spend an extra second or two. So let's get into it. This is going to be long form, meaning I'm just going to walk my way through it. If you want a short form written summary of what I'm about to say, I'll probably type it up and I'll post it on academia and various whatever social media sites, assuming that it doesn't get censored by big tech. But this is a good exercise piece. You know, we all need to challenge ourselves to be analytical. Uh, I don't know that we would necessarily want to be analytical all the time in every aspect of our lives, probably not. But we do need to have the ability to turn on that faculty and that facility to be able to think critically, to be able to read something and say, this is right or wrong, or I agree or I don't, or hey, what's going on here? Again, before I get into this, I'm going to invite you to look at the article yourself, or at least read the first page, and make your own decision to kind of see where you are in relation to the review that I'm about to provide. You know, for example, I think about this every once in a while. When I was a kid, Generation X, thank goodness. When I was a kid, I remember, I feel so lucky to have been Generation X, for one thing. But I do remember growing up, when I was in elementary school, we had a reading class, of course. We used to sit on the floor and the teacher would read, and then sometimes we would read and all that kind of stuff. So we had a reading class. I'm talking about, you know, like in the 3rd grade. That was Mrs. Onstead, to be exact, and then Mrs. Hall in the 4th grade, and Mr. Battles in the 5th grade. So anyway, I remember being in grade school, and we had a class called reading, but then we had eventually at some point we had a different class, and it was called reading comprehension. Well, just the change in the name of the course tells you a lot. So reading isn't simply reading. Like, I would expect that most adults, most quote-unquote educated adults, could read this article. But the question becomes, can you read into this article? Can you read the details? Can you read for nuance? So, you know, reading is one thing. Most people could read this article. Most professional adults could read this article. But can you read it and understand kind of what's behind it? So most messages, especially official government organizational messages, most messages have a superficial message, and then accompanying that, but a little more subtle, they have a meta message or something beyond the superficial message. So whenever you're reading a political document, and everything in medicine now is political, anytime you're reading a political document, you need to, if you want to understand it, I mean, what's the point in reading an article if you're not going to understand it at a more profound level? If you're just going to read headlines from the news, then read headlines from the news. If you're going to read science, you have to do more than simply decode the letters on the page. So what is the message? What is the bias? What are they trying to accomplish? What's the meta message? And what's the action point that you would take away from this publication if you were to read it for what it is or how it presents itself? So all of that. So we'll walk through it. So my last drops of coffee, and here we go. So what I invite you to do is compare your reading of this article with my reading of this article. Again, this is pretty spontaneous. I've barely finished reading the article. I haven't invested a lot of time into proofing it and cross-checking their whatever. But let's just go with what you could reasonably do if you didn't even care about this article, but you read it anyway, and then you wanted to say something about it. What could you say about it? What could your impressions be? Let's get into it. We're going to start with the title. Well, first of all, let's start with JAMA. So JAMA, the American Medical Association, is notoriously anti-nutrition, anti-integrative medicine, anti-functional medicine, anti-anything that would take away from the prominence and glory and profitability of the pharmaceutical industry and the medical profession. They basically exist to promote the medical profession and its interests. Now, decades ago, the medical profession was one thing and the pharmaceutical industry was something else. And the medical profession kind of led itself, at least more so than it does now. But now the pharmaceutical profession absolutely controls the medical profession. I'm talking general medicine, I'm talking family medicine, I'm not talking surgery. I actually love medicine. There are a lot of medical drugs that I think are great. I love emergency medicine, I love urgent care. I think orthopedic surgery is awesome. Neurosurgery, of course, is great. So there are a lot of things within the profession of medicine that I really like. But the profession is also tightly controlled by the pharmaceutical industry in many ways. Most of the journals, the editors and the reviewers for the journals, most of them have ties with drug companies. Anytime a journal publishes an anti-nutrition article like this, they can resell the reprints to the drug companies for millions of dollars. So organizations and journals in the medical world have a bias against nutrition because they're trying to protect their territory, they're trying to protect their advertisers, and they're trying to sell reprints of any article that makes nutrition look bad and makes drugs look good. And that's before we even get into the politics of the Great Reset. So, okay, let's get into it before my blood sugar crashes or my caffeine wanes. Effect of high-dose zinc and ascorbic acid supplementation versus usual care on symptom length and reduction among ambulatory patients with SARS-CoV-2 infection, a randomized clinical trial. So you'll notice that this is not placebo-controlled, for one thing. Symptom length and reduction among ambulatory patients, usual care. So if this is a comparison study, they would have to define what the treatment is and what usual care is. Any study that's going to be published, part of publishing a study is to detail the methods and materials so that another honest group of researchers, theoretically, could replicate the study, or at least the study design, to see if the results are valid. So if they don't describe the methods adequately, then they're making it impossible for any other group to replicate the data. And the other boundary I'm setting here, and I could set this boundary or not, but I'm not looking at their supplemental material. I'm going to take this article at face value. Now, we'll see what their conflicts of interest are. I presume they say that they have no conflicts of interest. Typically, when they say they have no conflicts of interest, that means that the conflict of interest statements are online, separate from the document. And if you read those conflict of interest statements, typically you'll find that nearly all the authors are paid by drug companies. Or they work for a medical school that receives grants from drug companies that directly compete with whatever they're studying here. So the authors can say, oh, well, I have no conflict of interest, but they're being paid by a medical school that receives drug money that has an obvious conflict of interest. So the money gets laundered through the medical school so that the authors can then bash nutrition and then say, oh, yeah, well, we're independent researchers. So anyway, let's get back to this. I'm going to stick to the topic. High-dose zinc and ascorbic acid supplementation. Okay, you're already being lied to by this article, and if you're a good, attentive graduate or doctorate level reader, you need to be able to read documents and know when you're being lied to, okay? High-dose zinc and ascorbic acid supplementation. They did a very typical job. So everything that they did here, I've already seen before, and that makes my review of this a little easier. So high dose, that doesn't mean anything to you, and it doesn't mean anything to me. So high dose is a stupid statement right off the bat. But they're already lying to you. I'm telling you, the title of this article by itself is already lying to you. It's already misleading anyone who would read it. Here they call it high-dose zinc again, and you can tell in my own reading of this, I put an X next to it because I wanted to make sure that I I caught it and saw it. So here they say high dose zinc. Here they say high dose zinc. So they're trying to tell you this is high dose. Here, a third time, they're saying high dose zinc and or high dose ascorbic acid. Open label. So why would they do an open label? Here's why. With a pandemic disease, the biggest pandemic disease maybe in history that we've seen, but certainly in our lifetimes, and certainly at a point in time, which is now, that coincides with the greatest development of research, sophistication, technology, interventions, everything. Why are they doing an open label trial? Why not do a legitimate study, a randomized placebo-controlled crossover study or something like that, if they could do crossover? In this case, they couldn't do crossover because the duration wasn't long enough. But here's what I'm noticing in the research world with regard to nutrition, with regard to COVID. First of all, where are the studies? You're telling me that this disease is urgent, it's critical, it's overwhelming the hospitals, it's overwhelming the healthcare systems, it's a pandemic, it's a crisis, and no one can put together a decent, competent research study for the biggest emergency we've seen globally. No philanthropist can fund a decent study using nutrition. No university, even the elite universities in the UK and the United States, none of these people can get it together to put together a decent placebo-controlled randomized double-blind study. You're really telling me that? And then you're trying to make it look like, oh, well, we're doing all we can to prevent this problem. You're not, the medical community, they're not doing anything other than kind of maintaining control over the situation. So why hasn't anyone, philanthropists, billionaires, universities, the American Medical Association, the Lancet, the British Medical Journal, all of these big medical organizations that receive millions and billions of dollars, especially of taxpayer money, why can't any of them put together a competent nutrition study? The answer is they don't want to clarify this topic. Open label trial and enrolled 214 adult patients with diagnosis of SARS-CoV infection, confirmed with polymerase chain reaction. Okay, well, this was last year in April to October. At that time, everyone knows that the polymerase chain reaction assays were being overcycled to pick up, dead DNA fragments. So they don't even address that in this article, but at this point, that side comment, well, or maybe it's an important comment, their methodology is flawed already. So I won't make a big point about that, but it is official news now. I mean, it's been known for maybe a year, but it's now official as of this year. Intervention. So remember, we're still in the abstract. Intervention. Patients were randomized in a 1-1-1-1 allocation ratio to receive 10 days of zinc, 10 days of zinc gluconate, 50 milligrams, ascorbic acid, 8,000 milligrams, both agents, or standard of care. Standard of care. All right, so I'm challenged. I have to challenge, and a good teacher would challenge you. You can take it or leave it. I mean, you can turn this video off anytime you want. But if you are at the graduate level of looking at research, if you're at the graduate level, if you are at the doctorate level of looking at research, then if you were taking a nutrition course or a nutrition seminar, then whoever's leading that course or seminar would have the right, I know it's so hierarchical, maybe it's paternalistic, they would have the right to challenge you. So I'm going to challenge you, and you can turn off the video if you don't want to be challenged. 8,000 milligrams or 8 grams. That's a decent dose. Some people might get gastric upset from that or diarrhea. A lot of times what I see in research articles published by American medical groups is they use an inadequate dose or they use a toxic dose, but they never use a perfect dose. A perfect dose would be 4 to 6 grams. I'm not saying 8,000 is wrong, but you can expect that some people will get a little extra gas and bloating and loose stools from that, so not a big deal. But they'll report it as an adverse effect. Maybe some of those patients were constipated, maybe they got a little loose stool and maybe they're happy, but they still reported it as loose stool, and even though it was a benefit, it gets reported as something negative. Okay, so back to the challenge. If you are at the graduate nutrition level or doctorate level, you should already see the problems with this study. It's on the screen right now in front of you. I'm going to let you think about it a little bit more, and then we're going to, when I finish the review here, when I finish the abstract, then I'll get into it. Primary endpoint was the number of days required to reach a 50% reduction in symptoms, including severity of fever, cough, shortness of breath, and fatigue, rated on a 0 to 4-point scale. Secondary endpoints: total symptom severity score of 0. Does anybody really have symptoms of 0 in their normal lives? I don't know. I don't. Cumulative severity score at day 5, hospitalizations, death, adjunctive, blah, blah, blah. Okay. Results, etc., etc. Patients who received usual care without supplementation achieved 50% reduction on day 6.7, compared with 5.5 for ascorbic acid, 5.9 for zinc gluconate, and 5.5 again for patients receiving both. Okay, so let's just stop there and talk about what just happened. So basically, the patients receiving ascorbic acid or ascorbic acid with zinc had a 1.2 day reduction in their symptoms, or in their kind of clearing of the clinical disease. 1.2. Gosh, that's almost exactly the same as Tamiflu. Tamiflu famously reduces symptoms of influenza by about 1 day, maybe less than 1 day, maybe a day and a half, but certainly in the ballpark of 1.2 days. And government, first of all, medical doctors use that drug, they prescribe that drug. Governments stockpile Tamiflu for millions, maybe billions of dollars. For what? To reduce the duration of influenza by about 1 day. So the same here. So you'll notice that they're about to say that this intervention didn't work. But it's exactly on par with the effectiveness of a drug that's embraced by the medical profession and embraced by governments, at least in the United States, where it's been stockpiled for millions of dollars. So we're looking at equivalent outcomes, but non-equivalent conclusions. So if nutrients reduce the clinical disease by 1.5 days or 1.2 days, that's considered ineffective. But if a drug does the same thing, they'll stockpile it for millions of dollars. They didn't use vitamin D in these patients, even though probably 95% of them were vitamin D deficient. They didn't talk about diet. And here's my other point, as you can see obviously here. They are measuring a reduction in symptoms for a disease that is notoriously minimally symptomatic or asymptomatic. Most patients who have this so-called infection, they don't have any symptoms. So you'll notice that in this article, they chose to use symptom reduction as a measure for effectiveness of treatment, But these patients are barely symptomatic to begin with. These patients are less symptomatic on a daily basis than I am. So, for other reasons, but it's hilarious. But anyway, this is what gets published. Excuse me. Conclusions and relevance. In this randomized clinical trial of ambulatory patients diagnosed with SARS-CoV infection, treatment with high-dose zinc. So let's back up just a little bit. So high dose number 1, number 2, number 3, and at least number 4. So on the first page, even if you only read the first page, they've already told you now that this was a high-dose study. No one who works in the nutrition world would tell you that 8,000 milligrams of vitamin C is high dose. No one would say that. High dose oral vitamin C is like 20 grams, 30 grams. That's a diarrhea dose for most people. But 8 grams is totally normal. I mean, 8 grams is not a big deal. 6 grams is not a big deal. 8 grams is still not a big deal. Yeah, some people will get loose stools from it, but not everybody. So let's go back to the biggest lie in this document. High dose zinc, high dose zinc, high dose zinc. They're lying to you every time they say that. But if you don't know nutrition, you're not going to pick up on it. High dose zinc. So they've told you now 4 times. They are relying on your ignorance for you to accept what they're telling you. So, and I'll let's just look at it right now. Let's go back to the intervention. Intervention, patients were randomized, 10 days of zinc gluconate. Here's what you need to know. Here it is. Here it is. You need to be ready for this. Zinc gluconate at 50 milligrams is not 50 milligrams of zinc. You'll notice that they didn't say 50 milligrams of elemental zinc, which is how this should have been written if this were true. If they used 50 milligrams of elemental zinc, they should have said 50 milligrams of elemental zinc, open parentheses, gluconate, close paren. So the detail here is in the way that they're describing the treatment. Zinc gluconate, 50 milligrams. That is not high dose zinc. They're telling you it's high dose zinc because they're assuming you are a nutritional fool and you don't know the difference between elemental zinc and zinc gluconate. If I say 50 milligrams of elemental zinc, I mean 50 milligrams of zinc. If we say 50 milligrams of zinc gluconate, that's only 7 milligrams of zinc. So in the zinc gluconate form, most of the weight is the gluconate. It's not the zinc. So when they say zinc gluconate, that's zinc plus the gluconate together, right? You've got zinc, you've got gluconate. Zinc is actually a small part of that molecule. The bulk of that molecule comes from the gluconate. In this case, 85% of the molecular weight is gluconate. It's not zinc. So the other approximately 15% is zinc. And in this case, if we're 15% of 50 milligrams, that means we're 7 milligrams per day of zinc. That's less than the recommended dietary intake. That's less than the recommended dietary intake for adults. But they're assuming that you don't know the difference. They're assuming that you don't know zinc gluconate from zinc. So, that is an educated I don't know, possibly an undergraduate level, but maybe a graduate level. That's kind of basic nutrition. If you've ever taken a nutrition course, yeah, I'm going to say this because it's true. If you have ever taken a good clinical nutrition course, even at the undergraduate level, you would have had a professor who explained to you the difference between elemental weight and chelated weight or conjugated weight. So zinc is typically administered with some type of organic acid or amino acid to chelate it or bind it or improve the absorption. So that's the standard. You can't have a competent conversation about zinc, especially in an academic environment. You can't talk about zinc supplementation without talking about the fact that it's always going to be conjugated onto something. If it's conjugated onto something, that other something, in this case gluconate, is going to have its own molecular weight, often much greater than the element that you're trying to bind. So in this case, zinc is only 14% of the molecular weight of zinc gluconate. So that comes out to 7 milligrams. This article is telling you repeatedly that this is high-dose zinc. This is not high-dose zinc. This is less than the so-called recommended daily intake. So again, they are lying to you. They are assuming that their audience doesn't know anything about nutrition. And for the most part, they're right. The journalists, the newspaper people who pick up on this article, or the television people, whatever, or the bloggers, the people who pick up on this article, most of them don't know anything about nutrition either. So they'll say, recently published by the prestigious American Medical Association in the prestigious Journal of the American Medical Association, even though it's not quite the same journal, they will commit the logical fallacy of what's called the authority fallacy. They will assume that because this comes from the American Medical Association and was published in a JAMA journal and is so-called peer-reviewed, they will jump to the conclusion that what's being said here is truthful. And it's not. I can't even get past the first page without telling you all the lies. High-dose zinc, high-dose zinc, high-dose zinc. Somewhere else they said high-dose zinc, high-dose zinc. It's not high-dose zinc. This is less than the recommended daily intake. They didn't measure or control for vitamin D. Most of these patients are deficient. They didn't do anything about diet. So here's another way that this article could have been titled. They could have said, patients on a junk food diet who test positive with for SARS PCR testing, which at this time was being performed in a mostly inaccurate way because of the cycle count. People on a unhealthy people on a junk food diet who are 95% vitamin D deficient. We don't even know what their other risk factors were, but let's just start with that. That's typical. This was done in the United States. In the United States, 70% of the diet is ultra-processed foods. 60 to 70% of the diet is ultra-processed foods. So we can assume very reasonably and scientifically, this isn't conspiracy, this is just being reasonable. A reasonable assumption is that all these patients are on a junk food diet, at least to, let's say, 60% effect. And let's assume that, I'll be mild and I'll say, let's assume that 80% of these patients are vitamin D deficient. It's probably more than that, but let's assume that that's true. Especially, they were already starting to be on quarantine at this point, and they didn't get a summer vacation, most of them. So no vitamin D, no diet. They are measuring for reduction in symptoms in an illness that's either famously asymptomatic or only moderately symptomatic. And they did a PCR test, which at this time was not being performed accurately. So treatment with high-dose zinc gluconate, ascorbic acid, or a combination of the two supplements did not significantly decrease the duration of symptoms compared with standard of care. Well, first of all, they're measuring for a decrease in symptoms in a disease that's barely symptomatic to begin with. It's most commonly asymptomatic. So they chose a pathetic marker to measure, which served their purpose for making the intervention look inefficacious or ineffective. So let me give you the flip side of what I had just said. Oh, but sorry, let me say. So they measured symptom reduction in an asymptomatic or minimally symptomatic condition. So no wonder the results weren't significant. And then they interpret statistical insignificance as inefficacy. And then they say, oh, well, we had to stop the trial because it was showing no benefit. They never asked the question as to whether or not their measurement was wrong. And they say did not significantly decrease the duration of symptoms compared to standard care. Did they ever define what that standard care was? First of all, we don't know if all these patients were already taking vitamin C and zinc and vitamin D and other things. So this is just a disaster of a study. But let me go back to what I had said now that I see my note here. Let me go back to my thought on this around the zinc dose. So we've already said, let's assume that the product was produced competently and that it actually provided 8 grams per day, 8,000 milligrams of vitamin C. Fine. Great. It may be effective, it may not be. I would expect maybe a little bit of benefit, but certainly some gastrointestinal problems, but mild. No big deal. Let's go back to the zinc. So I already told you, and again here they say they can't say it over and over again and then later deny it, which is another thing that I've seen. Remember I told you earlier, I said I've already seen all these problems before. So when I saw this article, I already knew I could already do pattern recognition on it and say, well, this is the same lie that they used back in 2004. This is the same lie that they used in the New England Journal of Medicine study in 2006. I mean, I'm already on this, kind of like a bloodhound. But let me clarify. My experience with the JAMA journals is that they will backfill data when they get challenged. So, for example, if I wrote a letter to the editor and I said, well, you didn't use enough zinc, what I have seen, and this is my interpretation, and it's a published interpretation in JAMA that I wrote and was accepted for publication. This was, I think, in 2004, it may have been 2005. 2004, I think. At that time, they published another stupid nutrition study. Nutrition's not stupid, but it can be studied in stupid ways, just like we're seeing here. So I critiqued the article. I sent it to the editor. JAMA published it. This was 2004. But then they allowed the authors, first of all, the editors eviscerated my reply. They took out all the points that I was making. And then they let the original authors backfill data and say, oh yeah, well, we published this in supplementary data. We did this, but we didn't document it, or we didn't publish it, but this is what happened in the background with our materials and methods. So anyway, that's how these journals function to maintain the image that they're trying to maintain. But let's give them the benefit of the doubt. I'm telling you that 50 milligrams of zinc gluconate is really only 7 milligrams of zinc. But let's give them the benefit of the doubt. Let's assume it's 50. At 50 milligrams, that's not an unreasonable dose of zinc, if we're talking about elemental zinc. That's not an unreasonable dose of zinc. It's not high dose. So they're lying to you by describing it as high dose, either way you look at it. If they're saying they used 50 milligrams of zinc gluconate and they're calling that high dose when it's not even the recommended daily intake, then that's a lie, obviously. It's a lie. If they're calling it 50 milligrams of elemental zinc and they're calling that high, that's not really high. In the nutrition world, high would be 200 milligrams of elemental zinc. For a few days, sure. However, in the nutrition world, meaning those of us who are actually literate in nutrition and use clinical nutrition and have experience and have studied it and all that, we would never use high-dose zinc by itself. You would never go to a good integrative nutritionist or functional nutritionist and just get vitamin C and zinc, and they would say, okay, yeah, you're going to be fine with your COVID. That would never happen. It would always be dietary change, vitamin D, selenium, multivitamin, maybe fatty acids, maybe whatever else. But it would never be done in this manner. Never. Zero. So this doesn't represent the clinically accurate implementation of nutritional therapy. If we were to use 50 milligrams of elemental zinc, we would always balance it with copper, because zinc and copper, let's just say they work together or they work against each other, or however we want to say it. But they both support immune function. So if you give a high dose of zinc and you don't balance it with copper, you're going to eventually provoke copper deficiency, and that itself is immunosuppressive. They make no mention of that throughout this publication. So zinc gluconate is 14% elemental zinc by weight. If they give 50 milligrams, then they have provided 7 milligrams of elemental zinc. The recommended daily intake for zinc in adults is 11 milligrams for men and 8 milligrams for women. So their 7 is less than the recommended intake, and yet they repeatedly called it high dose, high dose, high dose, high dose. 4 times they said high dose on the first page. 81% of patients with a confirmed diagnosis only have mild symptoms, and yet they used symptom reduction as the measurement of effectiveness in this study. I'll try to just say that one more time. They used symptom reduction at 50% as the kind of standard of efficacy for this intervention in a disease that's notoriously asymptomatic or mildly symptomatic. Ascorbic acid is an antioxidant that may play a role in immune defense. This is the year 2021, and they are still trying to cloud the issue of the importance of vitamin C in immune function. That's ridiculous. May play a role. Vitamin C definitely plays a role in immune function, and let's see if it works for this condition. Not it may play a role. Again, here they use the PCR, polymerase chain reaction based assay, which was notoriously improperly performed in the year 2020. And this was done in 2020. Here's the other thing. These patients were selected to participate in this study if they were likely to remain in the outpatient setting. So they intentionally selected patients who were mildly symptomatic and mildly ill. If their symptoms, let's say, or where's my camera? If their symptoms are only this high, let's say short, let's say there's trying to make sure I'm in the camera. If their symptoms are only modest and you're measuring for a reduction in something that's already mild or modest, how far do you think it's going to go, and then be able to say that it reaches statistical significance, right? So they chose relatively healthy, unsick patients with mild symptoms, because if they had been more symptomatic to provide more robust clinical outcomes in this study, they would have already been excluded from the study. So by definition, the people who were engaged in the study as participants were already mildly ill or virtually asymptomatic, let's say, closer to the end of being asymptomatic. Again, here we go again. 50 milligrams of zinc gluconate. That's only 7 milligrams of elemental zinc. That's less than the recommended daily intake. They provided no measurements of the they did no independent assay of their products. So here's another paradox. The medical machine loves to say that nutritional supplements are unregulated, they're not quality controlled, they're unreliable, they're not as good as pharmaceutical drugs, which are also, especially in the generic form, have a huge margin of quality. So they say in other articles, they'll say, well, nutritional supplements aren't reliable and they're unregulated because they don't meet FDA standards. I mean, they say that. That's part of the propaganda message. But then they use those same supplements without testing the quality. Well, here's what I'm going to say. If we're going to be intellectually honest, we can't vacillate and we can't have it both ways, right? You can't say that the supplements are unregulated and unreliable and then use those supplements without testing them. So the medical profession, when they do research, that's how they move the goalposts and that's how they pick and choose what they want to say. So we're supposed to assume that these supplements are well made when they want to assume that they're well made, even though we don't know. They don't even list the brand. I don't think so. I don't even think they listed the brand or where these came from. So no measurements of quality, no measurements of absorption. They didn't even look at any surrogate markers. So they could have looked at high sensitivity C-reactive protein to see if the supplements are even being absorbed. They could have measured histamine levels in the blood or urine to see if the vitamin C was working. So for example, and here's maybe this is an expert level point, I'm not sure, but we'll go with it. I've known this for 20 years, so sometimes hard for me to say what's expert and what's not. People who receive this dose, 8 grams per day of vitamin C, would have a reduction in their serum histamine levels or an increase in urinary renal excretion of histamine. So they could have measured that as a surrogate marker to see if the supplements were working. That would be very reasonable. They didn't do that. So they either didn't know or they didn't want to know. Or more important than producing bad research or good research is producing confusing research. Their goal is to confuse the topic, and they succeeded again. So no measurements of quality absorption, surrogate effects, or prior diet. So all of these people could be eating beer and French fries and candy bars, and then they got 7 milligrams of elemental zinc and 8,000 milligrams of vitamin C. That's not a competent nutritional study, especially if they're vitamin D deficient. And they're probably 90% of them are vitamin D deficient. Oh, here's another thing. In the original analysis plan, patients recorded a questionnaire with only 4 symptoms: fever, chills, shortness of breath, cough, and fatigue. However, based on CDC guidelines, the study protocol was amended, and the symptom questionnaire was expanded to include all these other things: fever, chills, shortness of breath, cough, fatigue, muscle or body aches, which goes with vitamin D deficiency, headache, new loss of taste, which goes commonly with zinc deficiency, but you're not going to recover a loss of taste or smell due to zinc deficiency with 7 milligrams. Not in a few days. New loss of smell, congestion or runny nose, nausea, vomiting, diarrhea. So that's great. So they added nausea, vomiting, diarrhea when they knew they were giving a dose of vitamin C that causes loose stools. Perfect. But my point was this, that they, in the middle of the study, they changed the way that they assessed the study. So remember what I said at the beginning of this meandering conversation? We are more than a year into the supposedly biggest healthcare global crisis we've ever seen in our lifetimes. And yet here's a study just now being published, and they changed the assessment in the middle of the study. Why haven't they done a basic competent nutrition study? I'm talking about all these so-called elite medical schools in the United States, or even a basic medical school. The nutrition industry, likewise, could have, I presume, funded a competent nutrition study run by, designed by, supervised by legitimate experts, not people who have never studied nutrition. medical journals could have said, hey, let's get some clear answers here. We'll publish your study if you do it right. Doing it right would be basic things: a multivitamin, a clean diet, laying off maybe the caffeine and alcohol for the duration of the illness. Selenium. Why selenium? Because it's anti-inflammatory, antioxidant, reduces. Where's my hand in the camera? Selenium is antioxidant, antiviral, reduces viral mutation, and reduces viral replication. So, let's not misrepresent the field and the science of nutrition by just using zinc, low dose zinc, and modest dose vitamin C. I mean, that's not how nutrition is practiced in the real world. But even if you don't care about nutrition, even if you don't care about anything I just said, you have to observe the fact that they changed the assessment method in the middle of the study. And they had a large number of subjects who refused to stop their supplements. So let's assume that, okay, so by definition, the people who entered into the study were willing to stop their supplements. That means they were taking supplements. So, for example, if patients were already on supplementation and then they just switched to the supplementation provided by the investigators, that's no intervention. That's leaving them as they were. On the other hand, maybe they stopped their supplements and maybe their supplements were better than 7 milligrams of zinc and 8,000 milligrams of vitamin C. So this is a filthy, poorly conducted study. Very curiously, you'll notice that their groups are mostly the same. Call it 50 people in each group. But they lost 14 to follow-up. Or they said it did not complete follow-up. 7 lost, 20 lost, 11 lost, 11. Why did they lose so many people? Maybe because of gastrointestinal benign. Let's call it benign. Benign gastrointestinal changes due to the vitamin C. But if we're going to look at this from a research perspective, just looking at research, not even talking about nutrition, you have to wonder, like, why did they have so many dropouts? That's a lot of dropouts. And here's one of my favorite parts of the study. Due to slower than expected enrollment, how can you have slow enrollment? How can you have slow enrollment in a disease that is supposedly a pandemic emergency, flooding the hospitals, global crisis, and they couldn't get enough patients? That doesn't make any sense. Oh, here's another part. Stopping for superiority. They would have stopped the study for superiority in the intervention. It would only be considered if the treatment group achieved a 99.999 level of superiority, statistically speaking. So the confidence in the superiority of the treatment would have to be 99%, but not simply 99%. It would have to be confidence level of 99.999, and at that point we would say the treatment was so superior that we need to discontinue the study because it would be unethical to maintain a placebo group. But stopping for futility would be considered if the power was less than 30%. So to stop, look at it again. Look at the difference in the goalposts for that statement. Stopping for superiority would only be considered at 99.999 confidence level. But we'll stop for futility at 30%. We'll just call it good. We'll say it didn't work. Really? I mean, that's incredible. But see, they're assuming, let me just say this my way, and you can take it or leave it. They're assuming, number one, that most doctors aren't going to read this. They're assuming most lay public wouldn't have a chance. I'm sorry to say that, but they wouldn't have a chance of reading an article like this. But the other thing that they assume, and this is true in the medical world, and you all know that it's true in the medical world. With all due respect for medicine, I love medicine. If I could be working in a hospital right now, I'd be working in a hospital probably, at least part-time. They're assuming that you're rushed. So you'll notice that, I notice this, everybody should notice this. One of the things that characterizes the medical profession from day number one of medical education is you do not have time to think, you only have time to form an opinion and go. Form an opinion and go. Memorize what they tell you, take your test, survive it, go get drunk the night after the exam, which is what most of my classmates did. We had a lot of binge alcoholics in medical school. But throughout, and I'm not saying everybody in medicine is alcoholic, but I am saying that a characteristic of the medical profession, from a big percentage of it, I'm not talking about elite surgeons, I'm not talking about people who have good jobs, but most of them are rushed. And they're not going to take the time to read these details, and they're not going to take they might read it and say, well, that's kind of weird. Why would they pick, I mean, look at this, I'm going to circle it. Why would they say 99.999 here, and then, oh, but we'll say it didn't work if it hits 30%? I mean, it's one sentence, one right after the other. Some of the patients were asymptomatic at baseline. So they had laboratory confirmed illness, but they had no symptoms. And we already know that the laboratory test at that time wasn't accurate, and maybe still isn't accurate. Asymptomatic at baseline, you have to understand this. They were asymptomatic at baseline, and the study used a reduction in symptoms as the measure of effectiveness. If they're already close to zero, they're not going to get much lower than zero. The study was stopped for futility. So they're trying to play the virtue signaling card there. What they're saying is, gosh, we just had to stop the study because there's just no point, and it would have been unethical to keep treating these patients for something that this doesn't work. I mean, this is worthless. Oh man. So they're so ethical they had to stop it for futility. Number of days to 50% reduction. These patients are more asymptomatic than I am. I mean, I go through my days with more problems than these people have. Let's see. Zinc gluconate. Primary outcome. Let's look at this. No significant difference. No significant difference in reduction of symptoms because the patients weren't symptomatic enough to even have a 50% reduction. Some of them. Patients who received usual care, 50% reduction symptoms at 6.7 days, compared with vitamin C group, 5.5. Zinc didn't work quite as well of course it didn't work. It was only 7 milligrams. And for people who received both, they bounced back to the vitamin C level at 5.5 days. So this is a reduction in illness of 1.2 days, almost exactly the same as Tamiflu, which is stockpiled by hospitals, used by the medical profession, defended by the medical profession, and stockpiled by governments for millions of dollars. And Tamiflu has some major life-threatening side effects. And so you're looking at therapeutic equivalents in a reasonable analogy. You're looking at therapeutic equivalents here, but they're saying it doesn't work. Oh, but they'll go write a prescription for Tamiflu. Total, et cetera, et cetera. So I'm going to try to bring this to a close, so you'll have to forgive me if I'm missing a detail here. If I find later that I'm missing a detail, I'll come back to it, but I've already kind of made my case. 3% died. That's, well, irrelevant or not. So these are the baseline characteristics. Body mass index. Hey, look! They're all overweight and obese. All of these patients are overweight and obese. All of them. If they are overweight and obese, then they are almost certainly living on junk food diets, not exercising, and they are also vitamin D deficient. 50% of the patients were quote-unquote black. Well, that tells you a lot about this study as well. I don't like using the term black, by the way, but I'm going to use it here for sake of easy communication. No, I'm sorry. They said 51 people were black, and that's 23%. So that's slightly more than the typical average in the United States, which is about 15%. So this is slightly disproportionate in favor of dark-skinned people, African Americans, most of them. But that also tells you about some diet and socioeconomic factors, right? Okay. 13% of them were diabetic. 13% of these people were diabetic, but in the zinc group, 12%, so about the same. But in the ascorbic acid with zinc group, it was double. Sorry, maybe I'm confusing. What's the percentage? So I'm sorry, this was the percentage. So they're confusing me. Here they say the numbers are in parentheses, and here they say the percentage is in parentheses. So that's why I'm going back and forth on this. So it has to be that this is the percentage. Either way you look at it, they had double the number of diabetic patients. Sorry, they're confusing the hell out of me. N equals 58. Why do they keep switching this? So here they're saying percentages in parentheses. They're confusing the hell out of me. Anyway, their groups aren't equal. Let's just leave it at that. Gastrointestinal corticosteroids. So it has to be that this is their percentage. So corticosteroids were about... Why would they have patients on corticosteroids? Almost 10%. Oh. Well, corticosteroids cause vitamin D deficiency is what I'm thinking. Anyway. Four-component score at baseline was all the same. Do you know how easy it is to get a four-component score of 4 points? I mean, that's easy. That's called waking up. Okay. Usual care. They never defined usual care, by the way. Here's the other thing. We're getting to the end, obviously, here. Here's the other thing. They define... In this bar graph, they define mild symptoms as 0 to 3. So these are hard numbers. These are whole numbers. This isn't a scale necessarily. So how can they include 3 in mild and 3 in moderate, just like they included 6 in moderate and 6 in mild? And they included 9 with severe and 9 with very severe. So this graph is just wrong. they should have said mild is 1 or 2, moderate is 3 or 4, severe is etc. Those categories should be distinct, not overlapping, because then how do I interpret this graph? What if somebody was a 3? Did they get put into this bar or the other bar? What if somebody was a 6? Did they get put into this one or the other one? This doesn't make any sense. For whole integer distinctions, they needed to keep those numbers distinct, not blend them together. I don't like that table. Standard of care, ascorbic acid. Yeah, so ascorbic acid worked. They got better faster. Zinc deficiency increases pro-inflammatory cytokines, of course, decreases production of antibodies, yes. Also does other things. Zinc functions as an antioxidant. It inhibits NF-kappa B. It reduces viral replication. Does a lot of things. Biologic activity of zinc. Oh, yeah, here's a good comment. I love this. I love this. You'll see this on social media commentary as well. However, the biologic activity of zinc against viruses may require ionophores such as whatever that is. I forgot. I've looked it up before. I think it's a drug. So I just gotta lay this truth onto you people. If you think that the human body cannot process zinc without a pharmaceutical ionophore, you're indoctrinated. I don't have anything. I don't have any other way to interpret that. So that's the negative truth. Now I'll give you the positive truth. The positive truth is, yes, the body can use zinc without co-administration of a drug. This has been one of the most ridiculous things I've seen in the commentary on zinc and this virus. Everybody thinks it's kind of like this pseudo-sophisticated commentary. Everybody says, well, you got to use an ionophore. You've got to use a drug so that the zinc can enter into the cell. Are you kidding? The body can use zinc without co-administration of a drug. Now, some of those ionophores are bioflavonoids like quercetin. So possibly an argument could be made that zinc, the cellular bioavailability of zinc, requires an expected phytochemical that would be in any healthy diet. I could go along with that, but I'm not going to say, I'm going to put a limit on saying that the body can only use zinc if you co-administer a drug. I think that's ridiculous. So let's bring this to an end. I think we're on the last page. Ascorbic acid can cause gastrointestinal intolerance, etc. It can cause diarrhea, and that's why they measured for diarrhea. High-dose zinc gluconate. It wasn't high-dose zinc gluconate. They planned, consciously or unconsciously, they planned for this to fail, and it failed. Oh, here's the other thing. Strengths and limitations. A novel primary endpoint in this study. A major strength is the pragmatic design. It's a stupid design. And a novel primary endpoint? Can these people possibly be so dumb and so uninformed that they think measuring symptoms is a novel primary endpoint? That's not novel. That's not novel. No placebo group. No placebo group. They didn't test. They didn't control for diet. They didn't control for prior nutritional supplementation. They didn't control for the quality. They didn't control for absorption. They didn't control for surrogate markers of biological response. It was open label. Everybody knew what they were taking. Patients were not masked to which therapy they received. Why couldn't they do a normal placebo-controlled study? They've got the money, they've got the talent somewhere. They could hire the talent if they don't have the talent. And you're telling me this is the best they could do a year into this pandemic? Recruited from a single health system, not representative. These results may not be broadly generalizable. This is ridiculous. So there it is. This is garbage, and you need to see it as garbage. So again, like I said at the very beginning of this meandering review, you can look at a study like this, totally deconstruct it, realize that it's completely stupid, and then see who endorses it. Because who endorses this study is going to tell you a lot. It was already endorsed by the organization and the journal that published it. That tells you a lot. It's already been picked up by the media because they don't have they're so-called journalists, but journalists these days aren't journalists anymore. You know, journalists these days are just reporters and repeaters. They're not even reporters. So a journalist is someone who actually reads, thinks about, critiques, investigates, cross-checks, verifies, looks for other sources. That's journalism. Reporting is just reading something and then putting it in your own words and then putting it on a blog or a press release or whatever, or maybe an article. That's reporting. Repeating is simply paraphrasing and then throwing it back out there. This is not a good study, and it does explain a lot, it does tell you a lot, but you have to read beyond the headlines. So thank you very much. If I give this article more attention, then I'll write it up. I'll write up a review, and I'll post it on social media and academia, and you'll be able to download it for free if I do that. Right now I'm kind of burnt out on this topic, and I need to go eat breakfast because, as you can tell, I'm getting a little woozy. So I'm going to go eat breakfast, and I hope that you enjoy the rest of your beautiful Valentine's, February 14th of 2021. Thank you again, and this has been Dr. Alex Vasquez, connoisseur of research, author of 100 articles, and a big book called Inflammation Mastery that all of you should read. If you made it this far, you should go ahead and read the book.